It's a real pleasure to be here amongst this illustrious group of cannabis cognoscenti, the PowerPod patients. Thank you so much to Americans for Safe Access for putting this on. My name is Philippe Lucas, and I'm a researcher with the Centre for Addictions Research of British Columbia. I'm founder of the Vancouver Island Compassion Society, one of Canada's oldest non-profit medical cannabis dispensaries. And additionally, I'm one of about 30,000 Canadians with federal authorization to use cannabis as a medicine. Today, I'm going to be presenting the results of a study titled Cannabis as a Substitute for Alcohol and Other Drugs, a dispensary-based survey of substitution effect in Canadian medical cannabis patients. My co-researchers on this project are my friend and colleague Amanda Ryman, Professor Mitch Earlywine, and 5 community-based dispensary representatives, Steph McGowan, Megan Olson, Dory Dempster, Brian Thomas, and Michael Coward. So what exactly is substitution effect? In a nutshell, substitution effect is an economic theory that suggests that variations in availability of one product may affect the use of another. Perhaps the best example of deliberate drug substitution is the common prescription use of methadone as a substitute to heroin, or of nicotine patches or e-cigarettes to replace tobacco. However, not all psychoactive substitution is the result of a deliberate decision made on an individual basis. At the population level, it's often the unintended result of public policy shifts or other social changes, such as cost, legal status, and availability. And so for cannabis-based substitution, whether it's for medical or for recreational use, it can be the result of economic shifts affecting end-user costs, such as health insurers covering the cost of medical cannabis use, shifts in policy that affect availability, such as state programs that have legalized dispensaries, or it can be psychoactive pharmacological substitution, like using cannabis instead of alcohol or opiates. Additionally, legal shifts that affect criminal risk and associated repercussions, such as the recent legalization initiatives in Washington, Colorado, can certainly affect use rates. My scientific interest in substitution effect is actually the result of personal experience. When I was diagnosed with hepatitis C in 1995, I initially used cannabis to help me quit alcohol and tobacco. And it was some time before I discovered that cannabis might also be effective at treating the symptoms and slowing the progression of Hep C. During the 10 years that I was executive director of the Vancouver Island Compassion Society, a medical cannabis dispensary located in Victoria, BC that I founded in 1999, I heard dozens of stories from patients who were officially using cannabis to treat conditions like HIV/AIDS or hepatitis C, but found that many of the benefits of medical cannabis use included reducing or eliminating their dependence on potentially more dangerous substances like alcohol, cocaine, heroin, and pharmaceutical opiates. The scientific framework for cannabis substitution is actually long-standing and fairly well established. In an examination of hospital drug episodes in 13 US states that decriminalized the recreational adult use of cannabis in the 1970s, Karen Modell found that users shifted from using harder drugs to marijuana after its legal risks were decreased. Findings from Australia's 2001 National Drug Strategy Household Survey specifically identifies substitution effect, indicating that 56.6% of heroin users substituted cannabis when heroin was unavailable. The survey also found that 31.8% of people who use pharmaceutical analgesics for non-medical purposes turn to cannabis when painkillers weren't available. Findings from Australia's To date, international drug prohibition has made clinical trials on cannabis as a treatment for problematic substance use nearly impossible. However, a number of studies on both humans and animals suggest that the cannabinoid system plays a role in dependence and addiction in both licit and illicit substances. For example, research shows that nicotine cravings can be modulated by the endocannabinoid system, and recent studies suggest that cannabinoid receptors interrupt signaling in the opioid receptor systems, affecting both cravings for opiates and withdrawal severity. Additionally, a study by the New York State Psychiatric Institute on people with cocaine dependence with comorbid attention deficit hyperactivity disorder found that cannabis users were more successful than other patients in abstaining from cocaine use. An earlier study by Labigolini Jr. et al. also noted this effect on people with a dependence on crack cocaine, reporting that 68% of the 25 subjects who self-medicated with cannabis in order to reduce cravings were able to give up crack altogether. And substitution amongst medical cannabis patients was also documented by, substitution among medical cannabis patients was also documented in a few studies by my colleague Amanda Ryman, most recently in a 2009 study of 350 medical cannabis patients in California. In the study, 40% of participants reported that having used cannabis as a substitute for alcohol, 26% reported using cannabis as a substitute for illicit drugs, there we go, and 66% as a substitute for prescription drugs. The most common reason for substitution were again cited as less adverse effects and better symptom management with cannabis. Additionally, in 2011, an analysis of 1,655 potential medical cannabis patients seeking recommendations from a clinic in California revealed that 13.2% reported using cannabis as a substitute for alcohol, and 50.8% reported using cannabis as a substitute for prescription drugs. Finally, exploratory research suggesting that cannabis use does not interfere with formal substance use treatment data from the California Outcomes Measurement Systems compared treatment outcomes between authorized medical cannabis users and non-cannabis users who were admitted to a public substance abuse treatment program in California. Although the sample was small, medical cannabis patient group fared equal to or better than non-cannabis users in important outcome categories such as treatment completion, criminal justice involvement, and medical cannabis concerns. In other words, using medical cannabis does not interfere with your drug treatment priorities. The research I'm presenting here today examines the subjective impact of medical cannabis on the use of both licit and illicit substances as self-reported by 404 medical cannabis patients recruited from 4 dispensaries in British Columbia, Canada. The specific hypothesis investigated in the study, which is the largest examination of cannabis-based substitution effect to date, include whether or not the use of medical cannabis affects the use of other substances according to a self-assessment of patient participants, whether or not these changes in substance use patterns result in net reductions or increases in the use of illicit drugs, and whether or not these changes can be attributed to substitution effect. In order to conduct this research, I teamed with and trained staff representatives in 4 medical cannabis dispensaries located in British Columbia to gather background and demographic data of patient participants as well as information on past and present cannabis, alcohol, and substance use. A 44-question survey, similar in scope to questionnaires designed by Amanda Ryman, was used to anonymously gather data on the self-reported impact of medical cannabis on the use of other substances, including but not limited to reductions in patterns of problematic substance use. The 4 dispensaries are the British Columbia Compassion Club Society, which is Canada's oldest and largest dispensary and currently serves about 7,300 members. The Vancouver Island Compassion Society, founded in 1999 and serving 1,400 patients. The Green Cross Society of British Columbia, which was founded in 2005 and serves just over 1,100 patients. And the Vancouver Dispensary Society, which was founded in 2008 and serves about 3,500 patients. While the first 3 dispensaries are located in Metro Vancouver with a population of about 2 million, the Vancouver Island Compassion Society is located in the Greater Victoria area with a population of about 250,000 individuals. The total survey sample for the study turned out to be 404 medical cannabis patients between the ages of 17 and 71, registered with at least one of the 4 participating dispensaries. The sample was 67.1% male, 71.6% Caucasian, and 12.5% First Nations Aboriginal, with a total mean age of 44 years old. Income levels were significantly lower than the Canadian average, with 58.2% reporting they had incomes of less than $20,000 per year. 24% report earnings between $20,000 and $39,999, and 17.4% earned $40,000 or more. This compares with about 63% of the Canadian population that report earnings of $20,000 and over, which is why it's often cited that that cost is a challenge for access for medical cannabis patients. When asked how about their primary method of ingestion, 48.8% reporting using joints or blunts, 10.4% used a pipe, 7.9% used oral ingestion, such as baked goods, oils, or tinctures, and 6.2% used a water pipe or bong. Although only about 44.17% report using a vaporizer as a primary method of ingestion, this is actually more than twice the rate of vaporizer use reported by Early Wine and Smucker Barnwell in a 2007 general survey of cannabis users. And that may suggest that this sample has a high commitment to potentially healthy ingestion techniques compared to cannabis users in the general population. 88% of patients reported daily use, with over 30% reporting that they use cannabis more than 4 times per day. 24.1% reported using 10 grams or more per week, 52.6% used between 6 and 9 grams per week, and 23.3% used less than that. In regards to substance use other than cannabis, 40% report current alcohol use and 49% smoke tobacco. Nearly 20% cite that they have used a drug other than cannabis or prescription drugs in the past 30 days, with the most common drugs reported being crack cocaine, heroin, methamphetamine, and MDMA, and 26.8% report a personal history of substance abuse. Additionally, over 52% were raised in an alcoholic or abusive family environment, and 19.6% state they've been treated for alcohol dependence, with over 5% participating in 12-step program and 3.5% in another type of alcohol recovery program. In regards to actual cannabis substitution, over 75% of respondents report that they substitute cannabis for another substance. 41% cite that they use cannabis as a substitute for alcohol, 36.1% use cannabis as a substitute for illicit substances, and 67.8% use cannabis as a substitute for prescription drugs. The 3 main reasons cited for cannabis-related substitution in the survey are less withdrawal, fewer side effects, and better symptom management, suggesting that many patients may have already identified cannabis as an effective and potentially safer adjunct or alternative to their prescription drug regimen. In light of the alarming rise in pharmaceutical opiate addiction and associated increase in opiate-related mortality and morbidity, as we saw from Mark Ware's presentation, a growing body of research suggests that cannabis may prove to be a safer substitute with a lower potential for dependence for those treating chronic pain. Additionally, since the intravenous use of opiates, crack and cocaine and crystal meth can all lead to the transmission of serious chronic conditions like HIV/AIDS and Hep C, evidence suggesting that cannabis might be an effective substitute for these highly addictive substances could be part of a public health-centered harm reduction strategy aimed at reducing disease transmission and overdoses from injection drug use. Furthermore, since alcohol has a far greater social health and financial impact on individuals and communities than all illicit drugs combined, public policy is informed by the growing evidence that cannabis might reduce or even treat alcohol dependence could have a significant impact on overall rates of alcoholism and consequently on alcohol-related automobile accidents, violence, and property crime. As we've heard here today, a growing body of evidence suggests that cannabis, once thought of as a gateway drug to addiction, may ultimately prove to be an exit to problematic substance use. With over 75% of respondents in this study citing that they substitute cannabis for at least one other substance, and given the credible biological, social, and psychological mechanisms behind these findings and other similar studies, further research is justified on both economic and ethical grounds, and perhaps clinical trials with those who've had poor outcomes with conventional psychological and pharmacological addiction therapies would be a good starting point. In the coming years, cannabis and cannabinoid-based treatments for dependence and policy shifts allowing adults safe, legal access to cannabis may ultimately increase the potential positive personal and public health impacts of cannabis substitution effect and subsequently decrease the suffering and social costs of problematic substance use and our failed and expensive war on drugs. I'd like to end by thanking the many cannabis patients who shared their thoughts and experience with us. I'd like to thank Americans for Safe Access for sponsoring my presentation and for organizing this amazing conference, and all of you for your time, interest, and attention. I look forward to your questions. Thank you very much.
Here, not only because we're all talking about medical cannabis, but so many of my favorite people are in this room that I rarely get to see. So it's been wonderful. I don't have a presentation right now. I'm just going to talk for a few minutes because Philippe did such a wonderful job of talking about cannabis substitution. So for those of you that I have not yet met, I am currently the California Policy Manager for the Drug Policy Alliance. But in my previous life, I was a cannabis researcher and did research on the use of cannabis as a substitute for other substances. And so I just wanted to add just a little bit of a more personal story on the end of Philippe's talk. And you know, we talk a lot about cannabis substitution, and people assume, well, you're not going to get high off alcohol or heroin, you just want to get high off cannabis. It's just a psychoactive substitution. But as Philippe alluded to in his talk, there's a lot more going on there concerning the endocannabinoid system and how cannabinoids play a role in signaling the brain and signaling us as human beings about what we want to do, what we want to ingest, when we want to go to sleep, when we want to get up, when we're in pain and when we're not in pain. And this follows through to addiction as well. So a couple summers ago, I was very lucky to conduct a study at Spark, which is one of the most fantastic dispensaries in San Francisco. And we looked at 8 active methamphetamine users that were seeking to reduce their methamphetamine use and were medical cannabis patients. So we did this great little study, and you know, if you have questions about it, I'm happy to explain more about it later. But the one aspect I want to bring forth is that when I was doing the pre-study interviews, so you know, I had these 8 patients, and I sat down with them one-on-one, and I asked them questions about their cannabis use, their methamphetamine use, their alcohol use, trying to figure out a little bit more about who they were and where they were coming from. And when I was sitting down with them, and again, they were not in the room together, this was individual one-on-one interviews with 8 participants, I asked them, how does cannabis help you when you are trying to not use methamphetamine? Like, what's going on with that? And what was so fascinating, and for a researcher, this is like this great aha moment, when you have 8 people say the exact same thing to you, almost verbatim, without any conversation with each other. And this is what they said. They said, you know, when I've been up for a few days, and I've been using meth for a few days, and I know I should go to sleep, and I know it's time to stop, and I know I shouldn't go out and try to score more, but there's this voice in my head that's saying, go get more meth, go get more meth. It'll be so much fun. You know you love it. You know that's what you want. And I want that voice to go away. And I smoke a joint, and that voice goes away. And I'm able to go to sleep. I'm able to wake up the next morning and feel really good about the fact that I was able to go to sleep and didn't go back out. And that's what cannabis does for me. Now, that's not a randomized, clinical, controlled, placebo, double-blind trial. But what it does is it gives us information that this is happening, that this is a phenomenon that's happening out in society, and then we can bring that phenomena to the laboratory and to the folks that can design these trials. But in the absence of government funding, the best we can do is to go out and ask the patients and take what they say and build that evidence up and publish it and talk about it until there becomes a tipping point where we can't ignore it anymore. And that's starting to happen. There are researchers now studying on the molecular level how cannabis impacts addiction. So it's starting to happen. But we, as medical cannabis industry folks and dispensary folks and activists, can play an extremely crucial role in developing that information. So the last thing I want to say is I'm conducting a workshop on Sunday. I think it's around like 4 o'clock in the afternoon, on collecting data at your dispensary. So if anybody is interested in trying to further this information and trying to capture what's going on with your patients or the folks in your community that are using cannabis, I would really love to see you. And we're going to be talking about survey design and methodology and really utilizing what we have, which is the largest sample of medical cannabis patients available to us in the world. So I hope to see you there, and I hope you guys enjoy the conference because it's going to be wonderful. Thank you.